Thank you, Dr. Deepamala, Sahani sir, and Vidi Patel sir. Good evening, good afternoon, and good morning. This is the 1741st day of continuous webinar conducted by International Forum for Promoting Homeopathy. Today, our guest is Professor Dr. T.AJAYAN. Let us begin the session with 1 minute silent prayer. Thank you all. The International Forum for Promoting Homeopathy comprises of homeopathic lovers, students, and doctors, and we have 3 sessions every day. The first session of the day is already over in Hindi from 7:30 to 8:30. From 8:30 to 9:30, we have the international session in English, and from 9:30 to 10:30, we have a local language session in Malayalam. We are uploading the videos of the same on the very next day itself so that those who miss the session can watch it again, and you can subscribe the same without paying any money. And the purpose of this forum is to take homeopathy to every home around the world. And let me come to today's guest. It is none other than Professor Dr. T.AJAYAN. Sir is the HOD and Professor, Department of Practice of Medicine, Sharada Krishna Homeopathic Medical College, Kulasekharan, Tamil Nadu. One of the best homeopathic medical college in India, and is a national level faculty of Institution of Homeopathy, Kerala, and the winner of Dr. N.K. Jairam Award, and has more than 25 years of experience, and sir has presented so many papers in this forum, and all the papers were brilliant, and really it's a very we are very happy to have such a faculty to this session. And today Doctor will be discussing about diabetes and food care in homeopathy, an approach to prevention and healing. So we proudly welcome the guest of the day, Professor Dr. T.AJAYAN. Yes, sir. You can.
Thank you, sir. Thank you, sir. Good evening to all. Respected the organizers of our organization IFPH and my dear doctors. Today's our topic related to diabetes mellitus. In diabetic mellitus and its common complications. Out of these complications, then the management of diabetic food care is our today's topic. Before the starting, I share my PowerPoint. Everybody know there is a diabetes mellitus. It's a global health issue. Then one of the disease under the lifestyle disease. Even that means the seed of all lifestyle disease is called it as metabolic syndrome. The metabolic syndrome, otherwise called it as Raven syndrome. Then after developing that different diseases in the form of chaos, in Malayalam we are saying avial. Then after preparation of the avial, we are not able to separate the vegetables. Like this, one of the disease, the diabetes mellitus. A diabetes mellitus along with the other systemic diseases, along with, that means like chaos. It's an global epidemiology shows the prevalence is an around 537 million adults. Then average in between 20 to 79 years where they're living with the diabetes mellitus in worldwide. It is a statistic shows into 2021. But another study shows the coming 2030, then only 5 years remaining, that is rise to 783 millions. That around 2030 to 2045, they are already calculating. That means nearly out of 10 adults, 1 adult is globally suffering from diabetes mellitus. Therefore, the coming days is a global issue, no doubt. Even this time also is a global issue. But then out of 10 people, 1 people is suffering from the diabetes mellitus. That means the coming days in our practice, then homeopathy practice, Out of that 10 patient is reach in our side, then out of the 10, nowadays the ratio is very high, but almost one people is suffering from diabetes mellitus. Then everybody know the diabetes mellitus, the broad division is type 2 diabetes mellitus and type 1 diabetes mellitus. The type 1 diabetes mellitus account for 5 to 10%. But at the same time, type 2 diabetes mellitus around 90 to 95%. Then mortality rates, one death in every 5 seconds related to diabetes and diabetes complication. That one death in 5 seconds is global. In India, that is the ICMR, then 2023, that is over 101 million people were suffering from diabetes mellitus.
Sir, slide is not moving, sir. First slide itself.
It's not moving, sir. Not now moving, sir. Not now moving. Around more than 136 million people are pre-diabetic stage. Then listen, then around 101 only now the diabetes state. 136 million people are pre-diabetic stage. Then in prevalence is more in India. The highest we are seen in Goa, Kerala, and Tamil Nadu. Then nowadays another trend is in rural areas also. Then previously is in urban area, but it is a major issue also in rural areas also. Then today our topic is diabetes and diabetic food care in homeopathy. Then and its approach to prevention and healing. Already I discussed with you. In age 35 to 49, there is average 9.19, while 6.63% has pre-diabetic. The age 50 to 54, the percentage is a little bit high, the 15.22 in diabetes and 7.18 and pre-diabetes stage in this particular age group. Then 50 to 69, that is around the prevalence is rise is at 21.8%. More than 60, then percentage is 43%. The reason for increase the prevalence in older age group, the reasons are, one is insulin resistance, then second one is in old age, normally the pancreatic dysfunction, then chronic inflammation, then sedentary lifestyle, then neglecting early symptoms. That is a major area that just you are workout in our clinical practice, workout in this area, you are consider this area, neglecting early symptoms. The symptoms like fatigue, frequent urination, blurred vision may be mistaken for the normal aging. They are mistaken. The normal aging is the presentation. The same presentation is there. Therefore, they are not workout. There is a diabetes mellitus. Then just I mentioned about the pathophysiology. The type 1 diabetes and type 2 diabetes mellitus is a common. The type 1 diabetes mellitus is an autoimmune attack of our beta cell. The beta cells apoptosis. Then therefore there is no insulin. Then absolute insulin deficiency that can lead to impaired glucose uptake in the cells. The main function is of our insulin is like then a particular traffic station, the role of a policeman, that is the role of our insulin. That is, it can lead to impaired glucose uptake inside the cells. This the policeman is not there. That is the transporting the glucose molecules never enter into the cells. Then type 2 diabetes mellitus, insulin resistance is in muscle and liver and fat. The increased insulin demand that is causing, that can responsible for hyperinsulinemia, that can cause beta cell dysfunction or the beta cell exhaustion, weakness, followed by relative insulin deficiency. Then again, is finally in pathophysiology, we are work out impaired glucose uptake in cells. Then in type 1 and type 2 diabetes mellitus, the hyperglycemia, what is the reason is different. The type 1 diabetes mellitus, the liver, it can causes, then affect the liver, it can causes increase gluconeogenesis. Then it can followed by decrease the glycogen storage and increase the hepatic glucose output that can cause for hyperglycemia. At the same time, in type 2 diabetes mellitus, the impaired the glucose uptake of the cells that can lead to muscle and adipose tissue, involvement of muscle and adipose tissue that can cause us decrease the glucose uptake, followed by increased lipolysis that can liberate free fatty acids, increase in the blood. It can cause us increased insulin resistance, followed by hyperglycemia. There is a very simple way I am presenting the pathophysiology. Then role of organ in diabetes mellitus. Then diabetes mellitus is affecting not only a single organ. Then a multi-system disorder. It can produce a multi-system disorder. The pancreas, liver, muscle, adipose tissue, and kidney. The role of normal glucose metabolism in relationship with these organs. Pancreas is produce more insulin. The changes in diabetes, the beta cells dysfunction and decrease insulin secretion. But in liver, that is the storage that stores the glucose as glycogen that can lead to diabetes, decrease gluconeogenesis and excess glucose production. In muscles, the major site for glucose uptake, insulin resistance that can lead to decreased glucose uptake. Adipose tissue, again the same. The stores of the triglycerides, that is can causes increased lipolysis, more free fatty acid and insulin resistance. In kidney, reabsorb the glucose up to a renal threshold. That is, glucose spills into the urine. That is glycosuria when threshold is exceed. Everybody know our renal threshold is 180 milligram. There is what are the complications, the common complication of diabetes mellitus. The first one is hyperglycemia. Is one of the complication. The hyperglycemia that can lead to the acute complication and as well as the chronic complication. Now we are first we are work out acute complication. The acute complications are mainly we are focusing the diabetic ketoacidosis and diabetic non-ketoacidosis. That is, these are the two complications there. It happens when the body has too little insulin, even in type 1, or the body parts cannot use insulin properly in type 2 diabetes mellitus. The hyperglycemia, high glucose sugar, blood glucose is considered when the blood glucose level exceeding 180 milligram per deciliter 2 hours after a meal or above 125 milligram per deciliter fasting. Here, the 180 milligram per deciliter is considered renal threshold. There are the pathophysiology of hyperglycemia. Then one of the major reasons are obesity, physical inactivity, certain medication, chronic pancreatitis, then certain endocrine dysfunctions like then excess cortisol leads to Cushing syndrome, then autoimmune disease of pancreas, high processed food. There nowadays here use processed food, high carbohydrate food, etc. Then all these things here leads to either insulin resistance or lack of insulin production. Then both are either insulin resistance and lack of insulin production that can lead to the increased glucose in the bloodstream. That is called a hyperglycemia. Then there are two complications we are already conveyed with you. There is an acute complication. That acute complication, the symptom of diabetic ketoacidosis and the non-ketoacidosis, that is called is hyperglycemic hyperosmolar non-ketotic syndrome. The hyperosmolar non-ketotic syndrome. These are the two acute complications. The symptom of diabetic ketoacidosis include, watch these warning signs are, the excessive thirst is the first one, the dry mouth, abdominal pain, nausea and vomiting, the fatigue and confusion, and fruity smelling breath. That just very, very important. In fact, the ketone smell, we are able to work out. If the patient is an arrive in our clinic, we are able to work out the fruity smell from the breath. That is just to think over diabetic ketoacidosis. The symptoms of the hyperglycemic hyperosmolar non-ketotic syndrome include, but the dangerous one is the second one, the hyperglycemic. The both are dangerous. Then diabetic ketoacidosis and hyperglycemic hyperosmolar non-ketotic syndrome also is making so many complications, no doubt. But out of these two, the hyperglycemic hyperosmolar non-ketotic syndrome is makes then coma and seizure. Therefore, we are carefully manage that particular situation, the hyperglycemic, hyperosmolar, non-ketotic syndrome. Then symptoms are high blood sugar is greater than 600 milligram per deciliter. Then frequent urination followed by dehydration and coma and seizure. These are the common presentation related to hyperglycemic, hyperosmolar, non-ketotic syndrome. Then, therefore, we are saying the ketotic complication, the diabetic ketoacidosis and non-ketotic acidosis. There is a difference than diabetic ketoacidosis, the characterized by the production of the ketone body. Then blood sugar level is between average 250 to 500 milligram per deciliter. Is a metabolic acidosis. The osmolality is normal. But in hyperglycemic hyperosmolaltic non-ketotic syndrome, there is a production of non-production of ketone bodies. The ketone bodies, the blood sugar level above 600 milligram per deciliter, but with the normal pH, but osmolality is elevated, which leads to dehydration. The dehydration finally leads to the coma and a seizure. These are the acute complications. Then another complication, there is a hyperglycemia followed by complications here, acute complication we are already discussed. Next one, you remember yearly vascular complication. Then vascular complication, you remember microalbuminuria. The microalbuminuria indicated there is a basement membrane kidney, then glomerular basement membrane damage. Therefore, we are already check the urine routine investigation. The routine investigation, the coagulation test is negative. But you are suspected or the previously diagnosed diabetic cases, you must advise microalbumin. The microalbuminuria is a urinary albumin excretion between 30 to 300 milligram per gl. The microalbuminuria develops from the dysfunction of the glomerular basement membrane, permitting albumin to enter the urine. That is the reducing the negative charge of that is glomerular basement membrane and allowing excessive amount of albumin to leak out. Everybody know the functions of our nephron. Either reabsorption or filtration. There is an here is an and a reabsorption defect. It will post mechanism is the combination of glomerular size is enlargement. The glomerular basement membrane is thickening and mesenchymal expansion, and the podocyte food process effacement and microalbuminuria can also occur in inadequate tubular reabsorption. Therefore, in our investigation also, we must include microalbumin. Check the microalbumin. Next dysfunction is endothelial dysfunction. The endothelial function is considered another complication. The diabetes mellitus, that means the glucose that can lead to the endothelium, the impairment of endothelium dependent vasodilation capacity that can lead to the increasing oxidative stress and inflammation and reducing vasodilatation factor activity, increasing the reactive oxygen species production. That is the endothelial dysfunction. That can lead to vasoconstriction. Is vasoconstriction that can lead to the change of the blood flow. The change of the blood flow Everybody know the plasma. Therefore, a normal constriction, due to endothelial dysfunction, what happened? This due to the vasoconstriction, the endothelium have a particular function is there. It's a due to the electrical activity, the normal repelling action is there. Due to this repelling action, the cells are traveling through the center and the plasma on the periphery. But the endothelium is damaged, the vasoconstriction or vasodilatation is there. Therefore, what happened? The repelling action is altered. Therefore, the cells are traveling towards the periphery. If the cells are traveling towards the periphery, first the adhesion of platelet that can cause atherosclerosis. There is another complication in diabetes mellitus. There is an atherosclerosis is one of the complication of endothelial dysfunction. The main reason is then oxidative stress. The oxidative stress that can lead to inflammation. Due to the inflammation, the chemical mediators are liberating that can lead to vasoconstriction and vasodilatation. Then another complication then associated with the diabetes mellitus associated with the development of hypertension. Then hypertension due to increased activation of then a renin-angiotensin mechanism. Then second reason of the hypertension in relationship with the diabetes mellitus is increased activation of sympathetic nervous system. And third reason for hypertension in diabetes mellitus is increased sodium retention. The sodium retention is directly involved relationship with the increased activation of renin-angiotensin mechanism. Then increased sodium retention that can lead to hypertension. Then another major complication is a chronic complication is a neurological complication. The neurological complication mainly due to either microvascular changes and or it's due to metabolic changes. The microvascular changes that can followed by the perfusion is decreased that can lead to nerve ischemia. That means the blood towards the nerves is decreased. That can lead to nerve structural and functional alteration of very first the peripheral nerves. That is the microvascular changes. The reason for the diabetes in a neurological complication mainly due to the microvascular changes. In microvascular changes, that can lead to the structural and functional alteration of peripheral nerves. Then another reason in diabetes mellitus is the metabolic changes. In metabolic changes, either the previously I discussed with you, that is oxidative stress, inflammation, or the mitochondrial dysfunction that can lead to structural damage to our nerve cells. If the changes happen to the structural or functional changes happen to the peripheral nerves, there are two types of presentation in clinical side. One is the painful diabetic neuropathy, another one is a painless diabetic neuropathy. The risk factors for the development of painful, there is a relationship with the genotype, but the major reason of the neurological complication mainly due to one is the microvascular changes and second one is the metabolic changes. Then the first clinical sign that usually develops in diabetes symmetrical sensorimotor polyneuropathy is decrease or loss of vibratory and pinprick sensation over the toe. This is a first level of presentation in relationship with the peripheral neuropathy. Decrease or loss of vibratory or pinprick sensation. Therefore, monofilament test, that is it's a home test, is very useful for to work out the sensation vibration defect. We are discussed later. Then another presentation, then a pattern that means the disease on progress, the level of diseased sensation may move upward into the legs and then from the hand to arm. Then this pattern is referred into the stalking glow appearance. There is a sensory loss. The later one by one. Then first one is the peripheral neuropathy. The latter affect the legs. The sensory neuropathy is an affect move to the legs and then to the finally then to the hands. The hands into the arms. There is a peripheral neuropathy. Peripheral neuropathy, these are the sensation. That is a lack of sensitization, the sensitivity to touch, then shooting or burning pain. Always the patient complaint of burning sensation. Sometimes that is an ulcer or the discoloration we are seeing on the foot. These are the classical presentation. Is relationship with the diabetic neuropathy. There is diabetic neuropathy and diabetic foot ulcer is a relationship is there. Diabetic foot ulcer is the most common complication of diabetic neuropathy. That is one of the complication of diabetic neuropathy is a diabetic foot. It occurs all over the mechanism, the peripheral neuropathy and vascular changes, and also due to improper wound healing in diabetes. There is a diabetes mellitus. There are diabetic foot ulcer. There are three reasons behind it. One is the diabetic peripheral neuropathy. Other two are, one is prolonged hyperglycemia. Then third one is the peripheral arterial disease. The peripheral arterial disease, the stress followed by the atherosclerotic changes. We are already discussed with you. Then endothelium is damaged, followed by the repelling action of the endothelium is followed damage is altered by the platelet adhesion. That is called atherosclerotic changes, followed by that is increased oxidative stress. That is a peripheral arterial disease. The diabetic peripheral neuropathy, then that is that causing the sensory dysfunction, motor dysfunction, and autonomic dysfunction. Then prolonged hyperglycemia, that can lead to the self-defense disorders and recurrent and repeated inflammatory response. Then all are leads to, the first one is the prolonged hyperglycemia leads to then defect in the wound healing mechanism. That means that is that the wound healing mechanism is not in the progress. That is the defect in the wound healing mechanism. And the peripheral arterial and the diabetic neuropathy and plus the defect in the wound healing is followed by in clinical side presented diabetic foot ulcer. The reason for the diabetic foot ulcer, we are considered one is the prolonged, we are controlled the prolonged hyperglycemia, and second, we are prevent the peripheral neuropathy, and also we are prevent the arterial disease, peripheral arterial disease. This is a protocol. The diabetic foot ulcer itself, that means we are ulcer cleaning, we are itself never help for any benefit for the patient. So simultaneously for the diabetic foot ulcer management, we are manage the hyperglycemia. So followed by we are treat the diabetic neuropathy and as well as we are correct the peripheral arterial disease. Then grades in clinical side, then always you remember there are 5 grades are there. Then first grade, there is no ulcer, the only symptom is present. Then grade 1, ulcer is formed, only present superficially. That is an involvement of the dermis, not in the subcutaneous level. But grade 2, the ulcer has gone deep in ligaments and capsule. And 4, the half of the foot has become gangrenous or ischemia followed by the gangrenous. The gangrenous changes begins to start in grade 4. But the total gangrene is formed, the cell death is there, with the putrefaction is there. The whole foot is become gangrenous in the grade 4 plus certain area with the shows the putrefaction. These are the grades of the diabetic foot ulcer. That is an pressure points is the common site for developing the diabetic foot ulcer. We have discussed later. Then another complication is the ocular complication. Everybody know diabetic retinopathy. Then first complication, diabetic nephropathy, retinopathy, neuropathy. Out of the major another complication, diabetic retinopathy. The involved there it will produce a microaneurysm. There is a dilatation of the small blood vessels. That is a diabetic complication. Is worsen lesion affecting the lesion single eye. There is a induced by the leakage from the breakdown of inner blood retinal barrier and is a microvascular occlusion. There is a diabetic retinopathy. Shows tension the contraction of blood vessels along with the hemorrhage. The initial stage of diabetic retinopathy is symptomatic. The advanced stage, the disease patient may experience symptoms like include floatase, distortion, and blurred vision. The earliest clinical sign of diabetic retinopathy is the microaneurysm. Next one is renal complication. The renal complication is due to uncontrolled hyperglycemia manifest in the form of the glomerulosclerosis and interstitial fibrosis and tubular atrophy. That means that basically I say there is a defect or the basement membrane defect is there. The diabetic kidney disease in critical metabolic impairment, the upstream influence of hyperglycemia leads to is dysregulated intracellular metabolism, inflammatory lesion, and increased apoptosis process and tissue fibrosis. That is a crucial step. There are 3 levels of complications are arrived. In 75% is the glomerular hypertrophy. And the second one is glomerular and tubercular interstitial inflammation. And third major issue is in renal complication is dysregulated cellular apoptosis. That is, there is a changes happen in the extracellular matrix. I am not going to the details. You remember renal complication. Then summary, we are already discussed an uncontrolled diabetes mellitus either is producing acute complication or chronic complication. Then acute complication, just to remember the ketone bodies formation and non-ketotic syndrome, that is hyperosmolar non-ketotic disease. Then chronic complication that can lead to then vascular complication, the neuropathic complication, ocular complication, renal complication. Then advanced complication means the end stage kidney disease. That is the last one is end stage kidney disease. Then just you work out what are the lab investigations we are used for the diagnosis of diabetes mellitus. Investigation always help for the diagnosis and monitoring and managing of the disease. Just we are work out the tests including blood sugar level, insulin function, and this complication associated with the diabetes mellitus. The fasting glucose level, just we are work out. The less than 100 is the normal. The pre-diabetic in between 100 to 125. Then if you test book, then below 110, normal range up to 110 we are considered normal. Anyway, then 110 below is considered a normal range in FBS. The pre-diabetic is in 110 to 125. The diabetes greater than 126 is a confirmed by repeat test. Through 1 or 2 repeated tests only, we are confirmed the diabetes. The measures of blood sugar after at least 8 hours of fasting, that is well and good the result. Then after 8 hours of fasting, only you are collecting the fasting blood glucose level. That is very, very important. 8 hours fasting is needed. Then postprandial blood sugar level, PPBS, they help to evaluate how to the body process the glucose. Then after a standard meal, no additional snacks. The blood samples is taken exactly 2 hours after starting the meal. The normal, then up to 140 milligram, below 140 milligram per deciliter. The pre-diabetic up to renal threshold 199 here we are mentioned. Pre-diabetic up to 180 here considered as a pre-diabetic state. Diabetes is greater than 200. Then random blood sugar. There is an advantage is an immediate result is there, but in postprandial and fasting blood glucose, the preparation of the patient is needed. But random blood sugar is an immediate result. The normal 140, pre-diabetic the same 140, 199, and diabetes greater than 200. No fasting is needed. Then for the treatment side, nowadays and helped by glycated hemoglobin, that is measures average the blood glucose in 2 to 3 months, is in relationship with the lifespan of RBC. There is a percentage of the glycated, that means the presence of glucose inside the hemoglobin is we are calculating. The normal is a 5.7 up to 6.4 we are considered as a normal. In few textbook, then 5.7 to 6.4 is considered as a pre-diabetic state. More than 6.5 is an diabetes. Then one more the value, just please note that is an exceeding 6.5. That is an existing, if a patient is diabetic, but the diabetic, the glycated hemoglobin level exceeding 6.8, that time reschedule our treatment. Or then reschedule the treatment means the right way you are manage that case, including general management and the medicinal management. There is an advantage of the glycated hemoglobin and its evaluation. Then next, we are concentrated the diabetic food care. The diabetic food care is, and first you are maintained or not. For that, the few tests we are used. One is the monofilament test. The monofilament test we are considered as the home test. Here the monofilament is kept in our clinic, and we are easiest way we are work out the sensory dysfunction. Then second one is the pedograph, and third one is venous Doppler ultrasound and biothessiometry. These are we are collectively used for the management of or the diabetic food care. You use for the diabetic food care. I repeat, monofilament and pedograph, venous Doppler ultrasound, and biothessiometry. The first one is the pedograph. The pedograph used for the plantar pressure distribution in the feet. The plantar pressure areas we are able to work out through the pedograph test or pedograph. That is causes an average in 5,000 and 15,000. Then electric pressure plates are available. That is a cost a little bit high. That is in with the 50,000 to 5 lakhs rupees. These are the two types of the pedogram. One is the manual and as well as electronic, the pressure plate. And my request, we are able to purchase these both and keep in our clinic where easiest way we are work out this pressure area, pressure distribution area. It's a very simple instrument, investigatory module. Then indication on the contraindications, evaluate food deformities, pressure point of heels, foot assessment, gait analysis, orthotic prescription. Then contraindication include open wound skin manifestation in skin infection. That time never recommended this test, the podagram test. The severe foot deformities are never recommended. Non-ambulatory patient and acute injuries that time being, please avoid this test. These are the contraindications. The procedure is very simple. The patient, the first you start the patient preparation, remove footwear and stand on a platform. The device setup and calibration ensure the sensors and working. The static foot analysis, then supposed to be electronic device, you ensure the sensors are working or not. Then measures weight distribution and pressure point. The dynamic foot analysis, that is record foot pressure and gait pattern while walking. Data collection, pressure mapping, and report generation and interpretation, and finally recommendation. There is and look, these photos are helpful to work out the high that red area, red indicated area shows high pressure areas. The higher to no impression, low pressure zones. There is no impression is there, low pressure zone. The high pressure zone, the darker the area. Here the darker is red in color. There is a normally the 0.25 to 0.2. Then a flat foot is slight 0.21. Then arch height, the ratio is 0.1 to 0.25. There is normal foot arch, even the weight distribution, flat foot, high ulcer, risk for diabetes mellitus. Therefore, these the pressure areas, we are carefully, you are again and again, we are check it. Every time, every visit, we are check the pressure areas. Then for what? That is a weight bearing areas. The weight distribution is equally you are distributed. But in flat foot, then high ulcer risk in diabetes mellitus, high arch also, the excess pressure on the heel and forefoot. Therefore, this electric pressure plate is helpful to work out the pressure areas. The pressure areas we are identifying, the need of the precautions we are advised to the patient. This is a manual pedograph, high pressure areas, darker, more pronounced region indicated higher pressure zone. The minimal contact or the pressure area is an absent of marking or lighter marking. Lighter marking or absent marking is an indicator the minimal contact or the pressure areas. This one is the manual pedograph. Then is a cost efficiency, the diabetic foot ulcer, the prediction, the meta-analysis indicate the pedography along with limited translation risk with pooled sensitivity or specificity 0.63 to 0.42 respectively. It should be used alongside other assessment for comprehensive risk evaluation. Then second one is widely used for workout neuropathy. We are used biothensiometry. Used for measure vibration perception threshold, that is VPT, in diabetic patient. Is the most commonly used in digital biothensiometer. In our Sharra Krishna diabetic food clinic is there. In diabetic food clinic, we are use all these instruments to work out diabetic food. That is cost is a little bit high. The indication and contraindications are indication, you are suspected case of diabetic peripheral neuropathy. Then peripheral neuropathy from alcohol, chemotherapy, and hereditary causes. It also is helpful to work out risk assessment, monitoring the neuropathy progression, and also it will help for the nerve function evaluation, post-surgical nerve function evaluation. Then contraindication in severe neuropathy with the complete sensory loss. In open wound case, never recommended that time. The time period, please avoid this test, biothensiometry. Then acute infection or inflammation at the site. Uncooperative patients also, please avoid it. Then another very important one is the contraindication is a metal implant or pacemakers. In that case also, please avoid this biothensiometry test. Then a cyto check of VPT, vibration perception test. The common sites are the big toe, that is the first one, the first metatarsal, third metatarsal area, fifth metatarsal. Then one step areas, that is an arch of the foot you are checking. Then last, that is a heel. These are the 7 areas we are work out. There is a vibration perception test. That is, we are use the handheld vibrator probe. The biothensiometer is an electronic device. Then first we start from after the preparation, the patient remove footwear, then must be clean and dry the foot, and probe placement. Then vibrating probe is placed on the first big toe, then ball of the foot and heel. The vibration sensation test, the sense intensity increases the patient's signal when they feel it. That just you ask to the patient. That is a measure the voltage at which the vibration is first felt. That should be you are recorded in our vibration perception test. That is the voltage in a measure the voltage at which vibration is the first felt. That is like this. Then 15 watt is less than 15 watt, then vibration is there. That is the normal. But then vibration perception test, the 15 to 25 volt, the mild neuropathy. but then vibration perception test the greater than 25 volt is an indicated high ulcer, that is a severe neuropathy, but sometimes you need amputation. It's the interpretation. That is vibration perception test. Voltage is then 15 is a normal. The 15 to 25 is a mild neuropathy, and more than 25 voltage is a severe neuropathy. The validity of this test, the study assessing the vibrance device is a type of biothesiometer demonstrated good diagnostic accuracy for detecting the peripheral neuropathy in type 2 diabetes. The biothesiometry has been considered a gold standard of early detection of peripheral neuropathy in diabetic patients. Then next one is the monofilament test. It's a home test, help to detect the loss of protective sensation, which increase the risk of foot ulcers and amputation. They check in their ability to feel. There is a 10G nylon filament only used for the test. That is a monofilament test. That is where place the monofilament of the perpendicular to the skin. Then apply the pressure until the monofilament is buckles. And then it is released. Then again, the testing the sites are first metatarsal, third metatarsal, and fifth metatarsal area, and also the big toe. The site shows that identity 90% of the patient with abnormal monofilament test. The indication and contraindication, the diabetic peripheral neuropathy screening, foot ulcers risk assessment, nerve function monitoring. Then again, contraindication monofilament test, the patient, the foot open wound ulcers, then severe edema is there, monofilament test is not able to work out. Then the thick callus is present on the foot, that is block the pressure perception, reliably. Therefore, these are the contraindication. These are the areas we are concentrate, listen. Then again, in severe peripheral vascular disease also, there is the result is shows the negative. The monofilament test in result and interpretation, normal sensation feels monofilament at all the sites. Then reduced sensation, patient misses 1 or 3 sites out of 10. 10 different areas, just you touch it. Then a patient is losses the sensation in 1 to 3 sites is indicated reduced sensation. Is more than 4 is indicated loss of the severe neuropathy, indicated severe neuropathy. This is an instrument, monofilament, a thin nylon fiber that bend at a specific pressure. The handle holder, usually the plastic metal or easy grip and application. Then another investigation is the venous Doppler. The Doppler study is and reveals to the percentage of the blood flow, and especially is for the DVT, because DVT one of the complication of diabetes mellitus, because it makes an atherosclerotic changes inside the veins. Therefore, venous Doppler study is helpful to work out the blood flow in the blood vessels. In diabetic care, the preliminary used to detect the manage the complication related to diabetic foot, the peripheral artery diseases. The uses, the detect the peripheral artery diseases, assess the blood circulation of the leg and feet, evaluate diabetic foot complication, check for venous insufficiency, monitor blood flow in diabetic wound, and post-surgical blood flow evaluation. This is a procedure. A gel is applied on the skin over the tested artery. The handle Doppler probe emits the sound waves to detect the blood flow and the blockage. This video is helpful for you to work out the venous Doppler study. The doctor analyzes the waveform and the blood velocity of circulatory abnormality. That means the Doppler study always you are done for in diabetic cases. Normal result, no clot, normal blood flow, compressible veins, and properly functioning the valves. But in DVT, the presence of clot, non-compressible vein, and reduced or absent of blood flow. The chronic venous insufficiency CVI is a valve dysfunction. The blood reflux is due to valvular dysfunction, vein dilatation, and swelling. Then for the researchers and as well as for the doctors, if the patient is an improve or not, for the assessment of the diabetic peripheral neuropathy, this tool is used. This is a validated tool. The various clinical studies use this tool. It's considered as a reliable and effective method for early detection of neuropathy. There are around 15 questionnaires there. There is Michigan neuropathy screening instrument. That is a predictive value. The score is less than 7 on the questionnaire. The 2 of the physical examination is considered predictive of moderate to severe neuropathy. These are the questionnaires. The 15 questions are there. Those who are interested, the practitioners, you must use the diabetic peripheral neuropathy assessment scale. It's also helpful to work out the prognosis of the disease. Whether after administration of homeopathy medicine, if the patient is improved or not, we are able to work out. Then in management side, the diabetic management for the diabetic mellitus, I'm not going into the details, but restrict the carbohydrate food. Then choose the complex carbohydrate. Then limit the carbohydrate intake the 45 to 60%. Then of the total calories per day. Then include the protein lean, prefer lean protein, the fish, poultry, beans, nuts, etc. Avoid the red and processed meat, and they increases the insulin resistance. Please note the red meat can cause increased insulin resistance. Therefore, please avoid in proteins. Please avoid red meat. In diabetic cases, please avoid red meat. Then fats, normally the you see healthy fat, olive oil, nuts, the seeds are just recommended. The fiber content food increase insulin sensitivity to prevent the spike the blood sugar. Then glycemic index control, that is a low glycemic index food is included. That is whole grains, ligaments, non-starchy vegetables, etc. Then sharp advice and exercise physical activity 150 minutes per week. Then always aerobic exercise you should advise 150 minutes per week, means average 20 to 25 minutes per day exercise. There is an walking and cycling, the strengthening training, the reduce the stress. Then the few medicines we have to discuss with you. 5 minutes remaining. The insulin resistance, the pre-diabetic with early type 2 diabetes mellitus. Here, the symptomatology is very important. We are widely used the CCGN jumbolna. In my practice, is an CCGN jumbolna is an control the sugar level, reducing the excessive thirst and urination. Then very first the classical symptoms of the pre-diabetic stage, we are using the CCGM jumbolna. Then cephalandra, the burning sensation in hand and feet. That is the beginning stage of diabetic neuropathy. The just with the excessive thirst and skin eruption is there. Just to think over cephalandra. In addition to this, one more drug you are remember, Bovista. Then Abroma. Nowadays, majority of the doctors are use this drug for the management of diabetes mellitus. But the symptoms, it's very important: weakness, excessive urination with the weight loss. One more drug is there, the phosphoric acid. But phosphoric acid, the indication in diabetes mellitus, a strong mental, emotional stress is there. We are indicated phosphoric acid. Then insulin resistant stage, pre-diabetic with the early type 2 diabetes mellitus, you are think over uranium, nitricum, and phosphoric acid. Phosphoric acid I will discuss with you in grief and prolonged emotional mental stress with the leanness. The symptom debility, increased urination, mental exhaustion. You think of phosphoric acid. The uranium nitricum, they are more effective in obese people. In my practice also, obese diabetic cases, I have used uranium nitricum with the excessive hunger, thirst and weight loss. But the patient is obese. You are thinking over uranium nitricum. Then this drug, the gymnema and lactic acid argentum metallicum is used for beta cell dysfunction. That is moderate and type 2 diabetes mellitus. Beta cell dysfunction is there. Progressive beta cell dysfunction is there. You think over 3 drugs. Gymnema, that is not the sugar destroyer. Beta cell, it will help for gymnema help for the beta cell regeneration and also reduce the sugar craving. Lactic acid is another drug. In my practice also, I am used the lactic acid. The diabetes, along with gastrointestinal symptom is there. Example, excessive taste, nausea, vomiting, bloating of abdomen. In diabetes mellitus, bloating of abdomen is common. Majority of patients in clinical site presenting bloating and dyspepsia. That is, you remember the lactic acid. Argentum metallicum is in weight loss and sleeplessness is there. Just you remember Argentum metallica. All these drugs in my clinical practice and relevant drugs only I will discuss with you. Then number of medicine is there. The symptomatology base, the totality base you have prescribed the medicine is a more effective to manage. That means a consensual prescription is more effective to manage. Then it's a complication of the diabetes mellitus and as well as the management of diabetes mellitus. Then advanced beta cell failure, insulinum, phosphorus, acid force, plumber metallica. The chronic complication for neuropathy, you think over phosphorus and sickle-core. The sickle-core, the numbness with the gangrene. The for nephropathy, Beriberi vulgaris and Apis mellifica. For cardiovascular disease, Crataegus and Cactus glandiflorus. For retinopathy, physostigma and gelsemia. Then the last stage in complication, the last stage is end stage of diabetes mellitus. You remember carbo veg, the weakness with low oxygenation, you are thinking about carbo vegetables. Then for arnica montana for wound healing, promoting wound healing, sickle-core for if you gangrenous, the 4th or 5th grade is there, just to think over sickle-core nature. Then this classification, this grade, the diabetic ulcer with the homeopathy management, the grades are very important. No ulcer in high risk food. The 5th grade extensive gangrenous involving the whole food. That is Wagner classification of diabetic ulcer. Then a stage-wise ulcer in homeopathy therapeutics. Then for example, pathology. The food at risk at neuropathy or pressure points, the phosphoric acid. Then superficial ulcer, partial for full thickness of skill loss. That is the grade 1 and grade 2, you are used the calendula officinalis. The Wagner classification, diabetic ulcer, grade 1, 0 and 1 and 2, you are used the calendula officinalis. The deep ulcer extends to the ligament, tendon, joint, capsule and bones. Yeah, just you remember 2 and 3. That is ischemia with infection. That stage, you remember silicea. This is at a butt says and all this one. Then deep abscess and with osteomyelitis, hepatosulfuricum, partial gangrene of forefoot, sickle cornetum, high risk of amputation, arsenicum album. Then last slide is a neuropathic ulcer. You remember arsenic album, carbovage, graphitis, platina, sepia, silicia, and sulfur. These are the drugs here collectively. And after in my practice, these are the drugs helpful to manage the neuropathic ulcer. But ischemic ulcer, you remember ischemic ulcer as well as neuropathic ischemic ulcer. Just you remember Bovista, graphitis, Helleborus, lactasis, nitric acid, petroleum, phosphorus, and tucuria. Then out of these, phosphorus is one of the best medicine, especially then ulcer on heels, foot edge, that particular area, the ulcer is there. That is an anatomy wise, I say, these are the medicines were more useful. There's a graphitis, the lactasis, nitric acid, Bovista, phosphorus, and tucuria. Then type of diabetes ulcer based on the anatomy, traumatic ulcer. Just you remember arnica, conium, magnum aceticum, venous ulcer. You remember ARDS, fluoric acid, lacasis, lycopodium, millifolium, pulsatilla, silicium, and sulfur. That is venous ulcer. Then based on the pathology, I already convey with you. Neuropathic ulcer, graphaitis, ischemic ulcer, Sickle core, neuroischemic ulcers, arsenic album. I repeat, neuropathic ulcer, graphaitis, ischemic ulcer, Sickle core, and neuroischemic ulcer, you are thinking about arsenic album. Thank you. Then once again, I extend my sincere thanks to the organizers, give me an opportunity to present a topic related to diabetic food care. Thank you, sir.
Thank you very much, sir. It's really, time is already over anyway. Dr. Nandulal, you can speak vote of thanks to the session also. Please unmute. Please unmute. Okay. Now I'm inviting Dr. Ramresa sir to say vote of thanks to the session.
Oh, thank you, Dr. Ganesh, and congratulations, Dr.T.AJAYAN, sir. Very beautiful describe the diabetes food management. So very, very thanks. Behalf of IFPH, whole team, very, very thanks. Again, presentation. Thank you, sir.
Thank you, Dr. Ramresa sir, and thank you, Professor Ajin sir,
Thank you,
and
sir. Thank you, sir.
those who attend the session in this evening. And tomorrow we will have a session from Dr. B.R. Bindu, a lecturer from Sri Vidyadhiraja Homeopathic Medical College, Trivandrum. And doctor will be talking about scope of homeopathy in neurological disorders. Thank you all, and wishing you all a very happy Eid Mubarak to all participants here, as well as those who watch from different parts of the world. It's the time to wind up the session, and so I am inviting Dr. P. Shaila to moderate the Malayalam session.
Very, very happy, Dr. Abdul Salam. Eid is very, very happy. Thank you.